Hello, everyone, and welcome. We are thrilled to see you all join us here today, and we're very excited to welcome Dr. Rüdiger Eichholz, all the way from Stuttgart, Germany, for today's live webinar, Mastering Ultrasound-Guided Procedures, 3 Pillars for Safety and Success. Some of you are joining us late into your evening and some early in the morning. Thank you for joining from all corners of the world. You're among 2,200 clinicians who registered for this popular webinar. A clarist first from Germany. As anesthesiologist, Dr. Eichholz has been using ultrasound for decades. He's well-versed in ultrasound-guided procedures and has perfected his ultrasound-guided interscalene brachial plexus block, one of the procedures he'll be demonstrating for us today. Now, research does confirm that when a brachial plexus block is performed under ultrasound guidance, it can improve the accuracy of the block and reduce the occurrence of related complications. The real-time guidance of ultrasound has the advantages of reducing the dose of local anesthetic without reducing the success rate and prolonging the duration of the block and the duration of the analgesia. Now, Dr. Eichholz invited us into his operating suite last month to capture real patient procedures on camera. So we'll be very lucky to share these cases with you so that you can see both high definition imaging in action and to see his scanning techniques, including imaging of the lungs and the diaphragm using the Clarius PAL phased array and linear scanner. I'll be your host for today's webinar, and thanks again for joining. Now, just before we begin, I'd like to share some literature related to today's topic. And I'd like to reference first an article from ASRA that we referenced in a previous webinar, and I think it still shows the best data we have so far regarding the increasing use of ultrasound for nerve localization. Now, there are so many benefits to using ultrasound, including hastening the onset of sensory and motor block, decreasing the performance time, overall fewer needle passes, reduction in the occurrence of LAST, and decreased intensity of hemidiaphragmatic paresis. All of these benefits result in better, safer outcomes for anesthesiologists and their patients. And after all the basics for safe and successful ultrasound-guided procedures, we'll discuss the intricacies of interscalene block combined with the cervical plexus block for shoulder and arm surgery, which you'll see today. Conclusions are that ultrasound guidance is becoming the standard of care in performing peripheral nerve blocks due to its advantages in real-time visualization of the needle and relevant anatomy, and higher efficiency and block success rates and reduce complications. Now, just before I introduce our guests, we'd like to understand our audience a little bit better. And so we'll just put out a little poll here and ask, what do you see as the risks and limitations to blind injections for the anesthesiologist? Great. Do you just want better visualization? Do you want to increase safety? So we'll give just a couple of more seconds. 3, 2, 1. Good. So I think most of you want to be more accurate and more precise and perform less passes. So I think you'll really benefit from this webinar today. All right. Now, just a reminder, please use the Q&A button to ask questions, and we'll have a discussion after the presentation. Let me introduce our guest. Dr. Rüdiger Eichholz is one of 4 chief anesthesiologists of Medici, which is a private practice for anesthesiology. His team delivers anesthesias at 50 different places in the greater Stuttgart area, more than 35,000 cases a year. And of course, ultrasound-guided regional anesthesia is part of it. With his small company, AEN, Dr. Eichholz has developed teaching materials for ultrasound training courses, and he has written a textbook, Ultrasound in Anesthesiology. He's also involved in the Ezra cadaver workshops. So without further ado, Dr. Eichholz, I'll hand the mic over to you.
Thank you, Shelley, for this very warm introduction, and welcome to everyone, dear ultrasound family and friends, for today's webinar. So the 3 pillars of safety and success. So we have prepared nice material for you tonight. So for beginners and experts, we hope to have some details to try out the very next day, which is tomorrow. So however, the density of information tonight will be quite high. So it is kind of unrealistic to memorize everything. So There are two ways for this to improve this. One is that this webinar will be available later on the AEN website and on our YouTube channel, and also in the Claris classroom. And so you can review the content again. And the other thing is, as I said, why don't you choose like 3 details from what I will be presenting to try out tomorrow? Because, you know, if you choose a detail now, it is more likely to improve your skills in the next days. So in order to get better every day, I would be happy if you find something interesting for you. And to make it even more interesting, why don't you share what you like and put it in the Q&A section? And you also can write all your questions you have, not only the details you like, but all your questions in the Q&A section, that we've got some material for the questions at the end of this session. So as you saw in the studies before, we keep telling people ultrasound makes everything better. But look at this. Is this really the case? This is, by the way, where I work. So it's kind of in the center of Europe. And Shelley told that the materials are coming from AEN, or a small work group with Wolf Armbruster and Thomas Noteisen. Okay, so look at this. A probe is used. We've got a vascular axis. And so a needle comes in. Oh, it is slightly too deep, little hematoma. We pull the needle back, second hematoma, and make it steeper, and another one. So what was wrong here? The good thing is ultrasound was used, but ultrasound as such doesn't improve anything. So in this case, the scanning plane and the needle tip, they weren't coordinated. So there was no needle tip control. And so what we should keep in mind, that we must never lose our needle tip. But how do we do this? This webinar will be about tips and tricks how to improve this and to have more successful procedures. So looking at this out-of-plane procedure, you can memorize that the needle tip must never be behind the scanning plane. However, it is in the right place on the way to the scanning plane. Look at another procedure. We've got like a typical positioning for a distal sciatic block, and the ultrasound image here. The needle comes in plane procedure. The common perineal nerve is just where the needle was now. Now it's on the tibial nerve, and look what happens. This is quite strange, isn't it? So, and now it's right in the tibial nerve. Despite good needle tip control, we can see the needle really well, but now it's blowing up the whole nerve. And if we look at this in the long axis, you see the needle tip in the center of the red circle here. The nerve has been blown up full length of the footprint, which is 50 millimeters here. So the question is, did this cause paresthesia? Did this cause permanent harm? I can tell you, no, it didn't. But the only reason is because we just demonstrated it after amputation. So we just wanted to show you how not to do this. So this was good needle tip control, but of course it was like we went into the nerve deliberately, and this should never look like this. Well, just to make sure that we talk about the same thing, we have like in-plane procedures and out-of-plane procedures. And of course, we also have like short axis views and long axis views, which refers to anatomy. And looking on the out-of-plane picture here, you see that the whole trouble with out-of-plane is that the needle has only just one cutting point of the needle with the scanning plane. And then the whole issue is, do I see the needle shaft or the needle tip? And we will address this later on. And the in-plane picture shows you that it always looks nice to have these pictures. However, there are two main challenges, which is a rotation error and which is lateral shifting, that we might not see the needle despite we're trying to have an in-plane procedure. Well, coming back to the 3 pillars of success and safety, do we only have 3? No, we have many, many more. And we've outlined like 9 different ones here. We will go over in the next minutes. And the blue ones may be kind of basic. The red ones may be more interesting for you. And we hope that we have details for everyone. So let's start with the probe handling. So the question is, what can we do with the scanning plane and the probe to improve the visibility of the needle. You all know like different probe maneuvers, like probe pressure, like tilting, like sliding, and all these. I would like to focus on three, which is tilting, rotation, and swinging, and three special movements, because we need, in this case, we need micro movements to control the needle. Let's start with the tilting. So whenever you do like an out-of-plane procedure, you may ask yourself, do I see the needle tip or the needle shaft? And whenever we are in the near vicinity of vulnerable structures like nerves, we must not work with the needle. So we must not move the needle. We have to work with the scanning plane. And this is micro tilting. So you see the needle tip here, and then you just tilt towards the shaft. You see these multiple reflex of an echogenic needle. And then you tilt back to the needle tip. And this is like how to differentiate between the shaft and the needle, very close to vulnerable structures. Well, we talked about the lateral shifting and the rotation error of in-plane procedures, and how to get rid of the rotation error is to use like micro rotation. You see the shaft here, but not the tip. And if you then slightly rotate the probe, eventually you will have the needle in full length in your image, and this is what you want. And the other thing is the lateral shifting. This is an in-plane procedure, and these videos, by the way, this is all in meat phantoms. And like by micro swinging, you can bring the needle into the scanning plane. The scanning plane has a thickness of maybe only 0.5 millimeter, so it's a very easy to have the needle parallel to the scanning plane, not seeing it at all. Okay, so this is how we can use the scanning plane and probe maneuvers to improve visibility. We can also use the needle itself. So how can we actually use the needle to improve visibility? And this is kind of basic bevel up. So we need to direct the bevel towards the footprint, the probe, because we've got better sound reflection in the bevel, as opposed to if we push it forward, like on the shaft or on the backside of the needle, we will have these conditions. So we just got to make sure that the bevel is directed upwards to the probe. And the second basic thing is in in-plane procedures, it is hard to see needles in steep angles. So whenever possible, we try to avoid this, and we try to insert the needle rather parallel to the probe to have better sound reflection conditions here. So the sound hits the needle and is reflected back to the probe like this. And this is possible in many different blocks like this one, or like tap block here. So on purpose, we do the skin puncture in a certain distance to the corner of the probe in order to have a more parallel course of the needle to the footprint. But sometimes we have steeper angles, and then it is a nice thing to also work with the probe and kind of open the door, put some pressure on the distal corner of the probe in order to have a more parallel course of the needle again. And by this, you will instantly improve your image and needle visibility. Let's come back to the needle itself. So out-of-plane injection, and we are not very close to the nerve, for instance. So we now can use the needle for identification. So we insert the needle out of plane. We will see like a white dot as the needle tip. And then if we deliberately keep on pushing the needle, we will have like these multiple reflexes as the needle shaft. And then we pull the needle back until we see the needle tip again. So working with the needle is one option to identify the needle tip in out-of-plane procedures. And what is also useful, you can hold the needle between your fingers and use it like a drill. So you rotate it between your fingers and you see like the multiple reflexes dancing in the image right now. And this sometimes just helps to identify the needle tip if you rotate the needle between your fingers. And of course, you also can do this in in-plane procedures. So you can, again, rotate the needle. You see the multiple reflexes moving. That helps identification. And additionally, because in regional, we most of the time use dull needles, and it is sometimes difficult to penetrate a fascial layer. And by using the needle like a drill, you can kind of sneak through fascial structures without getting a plop. And then, of course, you also can use an injection to open up spaces like in this hydrodissection here. And of course, also with non-echogenic needles, you can use rotation for needle identification, and you always can see the direction of the bevel. So this is what we can do with the needle. And then as another pillar, the third one is sonographic anatomy. Of course, we need to get better and better every day in sonographic anatomy. So we have to memorize everything we have learned years back in medical school. And so our idea is to have standardized scanning procedures to identify the location where you want to put your needle for vascular access and also for nerve blocks, of course. And you can read it in books. And I will quickly demonstrate you like our standard scanning procedure for the interscalene block or for the superior trunk block. And so have a look in our theater in Friedrichshafen at Lake Constance. Good morning, my name is Dr. Eichholz. We're performing an interscalene block with a catheter in a patient who's going to stay awake during the surgery. So I will also block the supraclavicular nerves with the local anesthetic, which I will use at the same time for the catheter. So I do pre-scan. The probe is connected to the iPad with Wi-Fi. And we can see the supraclavicular plexus here. And now I scan upwards. And see a wonderful artery here. And I scan further upwards. I see the superior trunk right here. This will be my target structure later on. And I see that the vertebral arteries are right here. And I can see that C6 is now coming into the transverse process. C5 is here right now. And C4 is here in the bony shadow, and I now follow C4 just slightly into what we call the cervical nerves pathway. Take a little bit of a spray again and put the local anesthetic in. Yeah, that was just an example on one of the options for a scanning procedure. And nerves it's so interesting to discover nerves. However, we have much more than this, like we can also scan the diaphragm. Look at this. Jetzt wird es mal kurz ein bisschen kalt. Okay. I put the probe on, the marker is directed towards the mattress, and now the image is frozen, and I can actually put on some voice controls and tell the machine freeze, and now it will defreeze. Now I've got a standard image. I could again optimize the image by voice control, like decrease depth or increase gain. And I also can start a video clip by capture video. And now the video is started. Take some, können Sie tief ein- und ausatmen, richtig tief atmen. Yes, we've got a dirty curtain coming in. Wieder ausatmen. Das sieht alles sehr gut aus. So this is a normal diaphragmatic function. Capture video. We'll stop the video. M mode. Okay, capture video. Jetzt mal richtig tief atmen und ausatmen. Yeah, very nice diaphragmatic function. So this is just one example on like how we can use this ultrasound for also like bedside workup of acute respiratory distress. And the other examination, what we need for a patient in dyspnea is, of course, a pleural scan. And if you look at this, we've got a standard pleural window with the pleural line in the lower part of the image. And now we zoom in the chest wall, and you see that every white dot and black dot and gray dot remains the same, whereas underneath the pleural line, there's this unsteady flickering image, which is due to the pleural sliding, because the mirror image or the mirror plane is being moved by the sliding. And also you can see the same phenomenon in M mode. And as most of you will certainly know, this is C-short sign and rules out pneumothorax on this particular place where you have your scanning window. And the C-short sign is a bit like this. So you've got a sandy beach yeah, this is a normal finding. So to rule out pneumothorax is easy, and whenever there is a reason and a patient with shortness of breath, it can be done. And likewise, the assessment of the diaphragmatic function. And of course, like for an interscaling block, we never do a rule-out or a Truer scan. This is just to demonstrate what is possible in POCUS. The next pillar is training courses. Of course, you can visit training courses and get tips and tricks and practical experience on scan models there. And the next one, and I'm not going to talk about this anymore. Practice is certainly one of the big pillars, because without practice, it is not possible to have a good learning curve. And practice also does include like lead phantoms to try out, and needle tip control is very useful to do it there. And but the next one, and that's again very important, is needle navigation. So what do you do when you want to bring your needle to a target structure? How do you control your needle? And we have prepared like a few methods. You see here, like for beginners and more advanced users, and we will quickly go over these details. So that is angle navigation. The first thing, very easy. It's a rough estimate. So we put a probe on. We're talking about, in this case, about vascular access. So this is an IJ on the right side. And we get the image and try to find out, how deep is our target structure? We have it like on the scale. So this is roughly 1 centimeter. And when we make the skin puncture exactly the same distance away from the scanning plane and do the puncture there, use a 45-degree angle, we then have got a rectangular triangle, and then we just put the needle in, and eventually the needle will reach our target structure on the 12 o'clock position in the scanning plane. And so and then we can do the puncture. This is only a rough estimate, because very often you aren't really on the skin perpendicularly. Maybe you don't insert the needle 45 degrees. You have like 50 degrees or 30 degrees. So this is a rough estimate, and this estimation error gets greater the deeper the target structure is located. So this is rather a method that is not so much suitable for nerve blocks. So it is suitable for structures you want to harm anyway, and this is typically vascular access. So you want to penetrate the interior wall of a vessel anyway. So this is a clinical example. We've got a femoral artery axis on the left side. This is a permanent loop in the video. You see on the 12 o'clock position, the needle that gets in, and you see the needle tip here. And at the same time, with a pre-inserted guide wire, the guide wire is inserted. So it works quite well. And of course, the distance from the skin to the scanning plane is invisible. But we have checked this anatomical situation in our pre-scan, so we know that there are no vulnerable structures on the way, right? Going back into theater, there's a little bit of an example of like an angle navigation for the supraclavicular nerves. Have a look here. Es wird nochmal kalt bei Ihnen. Und die Lokale. I keep my distance between the needle and the probe, of course, for sterility or hygiene reasons. Jetzt gibt es hier mal einen kleinen Pieks an der Haut. Okay, capture video. I insert the needle, go under the probe, and now I inject a little bit and split all the horizontal fascial layers. Then I take the probe off, go subcutaneously and tunnel subcutaneously in the direction where the catheter will be inserted in a minute. Now we will keep on doing some preparations for the sterile field. Yeah, this was an example for the angle navigation. It was a superficial structure. I was not targeting a nerve as such. I was going into the cervical nerve pathway, and it worked quite well. But with other method, which is, for instance, the walk down method with angle adjustment, which is more precise. So look at this. The probe is on again, and the angle is shallow. It's only like 20 to 30 degrees in order to identify the needle above the target structure. So the idea is to not hit the target structure with the first needle path. So the idea is to first of all have a superficial identification, and you see this in this video, and that's a permanent loop, I guess, and you see it in the sternocleidomastoid muscle. And whenever you see this reflex, you must not push the needle in. You have to stop the needle and pull it back. and then you make it steeper. So deeper means steeper, otherwise you get the needle tip behind the scanning plane, and this is uncontrolled, so we don't want this. So now you see in the permanent loop that the needle tip slowly, gradually gets deeper towards the target structure. You repeat this as often as needed to get to the 12 o'clock position of the target structure, as you can see here. And then you do a tiny little angle adjustment again and penetrate the vein here. And so this method is certainly better. It is more controlled. However, in vascular access, sometimes it is a disadvantage that the angle of the needle, how it comes onto the 12 o'clock position, is quite steep. So you may easily get kissing walls, and sometimes you may not really get the guide wire around the corner. So sometimes it makes sense to start the skin puncture a little bit in the distance in order not to have such a steep angle when you get to the vessel. Let's go back to theater, and let's have a look here. A little bit of liquid here, and now I take the syringe in my hand first, so I can actually aspirate and inject with my thumb, put the needle between my fingers here, make sure that the bevel is directed upwards towards the probe, and I do like the insertion in the skin without ultrasound because it is far up and exactly where I had the local anesthetic. Jetzt drückt's mal kurz ein bisschen through the skin, and then I use the same tunnel to go down here, and now I start with the ultrasound. The marker is directed to my own left eye, so it should be a good image orientation now. Increase gain, increase gain. Now I'm quite happy with the image. I go for the superior trunk, which is right here, and as you see, the artery is quite deep, so I'm not really worried about this, but I go slightly higher, that it's not going to be in my needle trajectory. Now I insert the needle very, very superficial. Now it comes to the superficial cervical fascia. I make it steeper to penetrate it with a little click. Okay, and now I inject it right here. There it is. So the spread of the local anesthetic is posterior to the superior trunk, and I've got like 5 milliliters right now. This is an example of how to use the angle adjustment, the walk down maneuver with angle adjustment in a clinical case. And let's just talk about this clinical case again. So why do we use the supraclavicular nerves additionally to the superior trunk? And of course, we do not necessarily have to do this. We use it like in catheters because we need the catheter to be tunneled a little bit. And so this is one reason, because otherwise the risk of dislocation would be much higher, because as you know, the superior trunk is sometimes only like 5 millimeters below the skin. So we need a little bit of a catheter tunnel. And the other thing is that we also have patients in awake shoulder surgery. So in this case, sometimes it's very helpful to, like, depending on where the surgeon does the skin cuts, to also have a block of the supraclavicular nerves, even for open shoulder surgery that is possible. Yeah, why a superior trunk? So in early days, we used to do the block much higher, like in an interscalene region, really. But now, as you know, the phrenic nerve, the course of the phrenic nerve is like this. So the deeper you do the block, the more distance you get to the phrenic nerve, the less likely you get hemidiaphragmatic paresis. And this is the reason. So when you look at the scanning procedure, when you start scanning from the subclavian artery, you scan upwards, you tilt your probe, scan upwards, and then you wait for the first bony shadow, which is here. And this is the transverse process, the posterior tubercle of the transverse process of the 7th spinal nerve, as you can see here. And you can also see the phrenic nerve on the anterior scalene muscle more superficially, and you can see the vertebral vessels also, and all the spinal nerves waiting to get into their transverse process. And because this is such a nice bony landmark, it kind of looks like a park bench, like here. So someone's sitting on there. And so whenever you see this, you know that for the location for your local anesthetic, you are already too high, because as you can see here, you've got the spinal nerve C5 and C6 separated as individual spinal nerves, and this is not yet the superior trunk. So when you now scan further down, you will get the nice formation with hyperechogenic connective tissue around the two, and this is plexus formation of the superior trunk. And in this area, the phrenic nerve will get more distance to it. So the idea is to hopefully not block the phrenic nerve, and this is like a normal diaphragmatic function after the block, but it also can be like this.
Deep breath. Okay, and again, nochmal ganz tief einatmen. Okay, und M-Mode. Capture Video. Jetzt nochmal tief einatmen. Okay, und nochmal tief einatmen, richtig tief einatmen. Okay, und jetzt nochmal so sniffen. Nochmal. Okay, und nochmal. Okay. This is a very typical image of a hemidiaphragmatic paralysis. So this is due to phrenic nerve block. As the volume spread, despite of, like in this case, 6 to 8 milliliters of local anesthetic.
So some people tell us, since I'm using ultrasound, I don't see hemodiaphragmatic paresis anymore. And the reason is that they don't look, because for most of the patient, fortunately, it has not a great relevance. But if you take the ultrasound and check after you block, even with the low volume, you will see quite a few phrenic nerve blocks. And of course, it is not only a matter of superior trunk block, it is also a matter of volume. So whenever someone is injecting 20 mils, there is like 100% rate of hemodiaphragmatic paresis. Okay, so let's get back to the navigation. We have a better method. So in this case, which is walk down with probe, alignment, and rotation, we again have a shallow angle and insert the needle out of plane until we see it in the superficial position in the scanning plane. And now we don't pull it back and make it deeper, but we just move the probe. So we move the scanning plane away from the needle tip that we don't see it anymore. And then we move the needle again into the scanning plane. So gradually the needle tip is guided to our target structure, and we do it as often as we need to see it on the 12 o'clock position of a vein in this case, and then we don't do the puncture, and then we rotate the probe and have then an in-plane procedure, and can then in a very controlled way put the needle in, like in the IJ here. And you see that there was a little bit of a lateral shifting here and a little bit of rotation error. So the probe always have to be in your hand, that you at all times can do micro movements. And because it's so nice, and because we pre-inserted the Guidewire again, we can insert it under full visualization. And that is really nice, and it's also fun. And as I said before, so if you identify a few details you really like and you haven't done before, why don't you write them in the Q&A section and share them, and decide what to use tomorrow. Let's go to the next pillar, syringe control. So when you do nerve blocks, who is injecting? You probably have a nurse doing this. And we all have experienced that maybe we had a bad day and our call outs weren't really precise. So we might have told to the assistant, inject a little bit, and how much is that? And then we might not have had good needle tip control. We didn't see anything, so we repeated this a few times, and all of a sudden the assistant is like, oh no, wait a minute, I got to change syringe. So 10 cc are somewhere, we don't know where, and this must not happen. So who's injecting? That's actually us. So the new and much more precise idea is that we have the syringe in our hand, and you've seen this on one of the videos before, that this is a good option for a very, very minimal volume, high precision method. And you don't even need like these pressure monitoring devices, because you feel it yourself. And this is really good. And this is an example on like a femoral triangle block And you see it here again. And I will quickly comment this on a meat phantom. So you hold the syringe in your hand that you can use your thumb for aspiration and also injection. And then there is a fake target structure in this meat phantom. And you see here that this is a walk-down maneuver with angle adjustment. So we make the angle steeper and steeper in order to approach the target structure. And as it is a fake nerve, we go not on the 12 o'clock position, we go tangential on the 3 or on the 9 o'clock position, and you see the needle appear. And you see like that there is only a very little volume we need for a good volume spread. And even a syringe change is possible in this single hand injection technique. So for us, this is the future method to aim for a high precision, low volume regional anesthesia, and that is syringe control. But we also have guidewire control. So look at this. So why, coming from the past where we didn't have ultrasound, why nowadays would we put a syringe on the needle when we do vascular access? So because we see where we are. So there is basically no reason apart from that we're used to doing it like this for so many years. So look at this. I just take away this little introducer and insert the pigtail in the needle, make sure, now it comes out, and I make sure that for the needle insertion, it is in the needle. I hold onto the needle like this, and I fix the needle with my 2 fingers and also press on the guide wire that it can't really be moved during the procedure. And this is now a walk-down maneuver with probe rotation, by the way. And as you can see here, this fake target structure is the hyperechogenic structure in the middle. And because the skin puncture wasn't really good, I do it again and now make it steeper. Go on to the 12 o'clock position of the target structure. And now I just rotate the probe. Yeah, there we are. Lift the probe, rotate it 90 degrees, and now with micro movements, you get rid of the rotation error and the lateral shifting. And now I go into this fake vessel. And of course, the guide wire isn't really going in very smoothly here, of course not. But you can see it really, really well because of this wiring, of the guide wire. It's very, very echogenic. So this is how it looks like. And of course, you also can then take the needle out and you have an instant position control of the guide wire in the tissue like this. And in a clinical case, it looks like this. So this is an IJ, and you go in. You also can see the kissing walls just in case you have them, and you go in and you know where you are. So there's no reason to use syringes any longer. And again, from the outside, this is a puncture of the axillary vein on the left side. This is how it can look like. And in this case, it's a demonstration of one of those devices that is holding the needle in plane. It is totally clean, no blood at all. And it is also really fun. And at the same time, you do the guide wire positioning control out of plane like this. So you follow the guide wire from the skin into the vein. And of course, you also can do this in the long axis. So you just turn the probe around, and in an ultrasound, it looks like this. So you've got, in this case, 2 hyperechogenic dots traveling down and into the vein here. And of course, that's also possible in long axis like this. So especially when you are using big dilators, there is a good reason to have a good guide wire control to be in the right position before you put big devices in. Another thing of guide wire control is what happens when you can't, when you get the right puncture, but then you can't forward the guide wire, like here. This is a case of a port insertion, and the surgeon couldn't really find the vein. So we are asked as anesthesiologists to make an ultrasound-guided puncture of the subclavian vein. And you see here but the pro position is also showing as an image in the supraclavicular area. The guide wire is somewhat going upwards. Even more in the supraclavicular area, you see the pleura here. You see also a short axis view of the internal thoracic artery here. And now we're scanning upwards in the IJ, and you see that the guide wire is in there. And part of the guide wire control is under direct vision to reposition the guide wire and to get it back into the position it should be. And this is what you see here. So we can use the ultrasound to guide our procedures under direct vision, and it makes it so much more effective and also safer. Well, the last pillar is catheter control. We also can control catheters. Let's have a last look in the theater right now for an out-of-plane procedure.
And the only thing that really needs to be sterile in this system is this little part, and I put it in a no-touch technique. And it's like a screw. So now it is in, and I can't put it in any deeper. And now, as always, I do a catheter position control. Freeze. Now we've got the image again, and this is the position I had before. Capture video. The video is running. You see the artery down there, slightly higher, and now I inject, and you see the spread is exactly where it should be. And now I've got in total 7 milliliters. Capture video will stop the recording. And now the only thing that needs to be done is catheter fixation and general anesthesia, and that's it.
And also there are other catheter systems. You can do this in plane and can actually see the position of the catheter. Like here, this is a subgluteal sciatic nerve block, and you can kind of play with the nerve with the catheter. And also, like here, this is a supraclavicular block of the brachial plexus. We just help you with the sonographic anatomy here. The green thing is the catheter, and the tip is in the muscle, in the interscalene muscle. And under direct vision, we can just slightly pull the catheter back. Now it's in the right position and can inject here. And this is how it should be. Well, so we talked about 9 different pillars on how to make our procedures more fun, safer, and more successful. And of course, you won't be able to memorize everything. You can do some reading, for instance, in one of these books. And the most important thing is that you have chosen, hopefully, like 3 different things to try out tomorrow. However, just keep in mind, whenever you try out something new that might never have been done in your department, you better talk to your consultant before in order to get some supervision to make it safer. And well, I think there is another pillar. This might be number 10. And of course, we need good ultrasound devices. And that's why I'm happy to hand back over to Shelley. And thank you for listening. I'm happy to take your questions later on.
Excellent. Thank you very much. Great, great stuff. So we have got the same scanner, the PAL, the linear and phased array. And I'll show the diaphragm first. So lift your arm. That's okay. Yeah. And then I'll just open up and cold here. Sorry. So I'm using the PAL scanner and the abdomen preset for this. And I'm just going on my model's ribs. And then the other thing I'll do here too is just turn on my voice control so that I don't have to touch my screen anymore. So when we start scanning, so we'll get a nice image of her diaphragm here, which is that nice bright white line that we're seeing right here. And as she breathes in, we can see that diaphragm move and out again. Excellent. And then if we want to confirm, I can use the M mode. Just tell the voice commands to use the M mode. And that just gives us a nice linear image of our diaphragm here, which is the bright white line. And it just shows us motion. So breathe in again. And we can see the diaphragm go up and out again. Great. And then just some quick breaths in and out. Great. Good. So no doubt about that. M mode. We'll just turn the M mode off. as well. Good. So then I can head up to the pleura. Bring your arm down.
Meantime, while you're finding the right scanning window, the reason for the hyperechogenic diaphragm is the same reason as for the hyperechogenic pleural line, because we've got a very, very high jump of acoustic impedance from the chest wall to the air. And this happens on the pleura right here, and it also happens on the diaphragm. So it's not the real thickness, it is an artifact. It's hyperechogenic.
Right. Yeah, sometimes artifacts are our friends in ultrasound, right?
Absolutely.
All right, so then again, what Dr. Eichholz was talking about was if we zoom the image, we see that the chest wall, there's no movement of the tissues other than a little bit of respiration. But then if we go down to the lung level, we get this kind of sparkly appearance below the pleural line, which is an indicator of lung. Great.
It is an indicator of like a normal finding. Of course, the lung, it is pure artifact below the pleural line.
Correct. Yeah. And then again, if we use M mode, this is where we're going to get our sandy beach appearance, seashore sign. Yes. Below the pleura here. Excellent. Good. And then I will just quickly go up to the net here. And I've got the nerve preset, and I'm just going to start low, just kind of point behind the clavicle here. All right. Now we've got our subclavian artery here.
So the question, Shelley, is where is medial, where is lateral?
So this is lateral, and this is medial.
So the plexus sits on the rib at the moment, and this is lateral to the artery.
Here.
Right, and you also see the pleura and the rib. Yeah, excellent. And this is a very nice view. Yeah. So we even can see like the lower belly of omohyoid muscle with the suprascapular nerve right now. So that you sometimes can see it. It's right there in the middle of the image on the posterior edge of the rib. Yeah.
Right here?
Yeah. Yeah, very nice.
Great.
Yeah.
Good. And then I'll just slowly scan up and just follow the plexus up to the interscalene level here. Ooh, there we go.
A little bit more medial.
Yeah.
Yeah, there it is.
There
So
you go.
find the park bench. So where is it?
The park bench.
Yeah. Yeah,
it's right here.
Yeah.
I will never forget that now.
And so you see that like on the bones, we get a very bright reflex. And this is also again due to a sound reflection, because the sound travels in bone like 3,000 to 5,000 meters per second. So the jump of impedance from like the normal tissue of 1,540 to 3,000 is very high. So there is a lot of reflection. And this is why we get like a hyper echogenic line on top of this park bench, like a little bit of a snow cap.
Great. Good. And there's the plexus. Right.
Yeah, and whenever you are seeing this park bench, you see like the rounder structure sitting on this bench is the spinal nerve number 7. And if you scan further down again, just scan, yeah, well, that is a C6, that was C6. But if you, yeah, now you see that there is a connective tissue encoding C5 and C6, and they sometimes can be seen also as multifascicular structures, and this is the superior trunk. Mm. Now please scan further upwards to demonstrate the transverse process of C6. The spinal nerve is right in the middle of the image. Yeah, there it is. That was C6. Again, hyperechogenic line. Yeah.
And then good.
Yeah, this is that was spinal nerve number 5. It kind of looks like the bony shadow as if someone was catching like a baseball with like a baseball coming out of the deep neck. And if you scan further up, you can also see number 4. Scan further up. Yeah, that was 5. Further up. Yeah, and that is 4, the bony shadow of number 4. And now below the sternocleidomastoid muscle, we've got this hyperechogenic connective tissue layers, and this is the cervical nerve pathway for the supraclavicular nerves, and also for the cervical plexus, like for carotid surgery, or thyroid surgery, or clavicle surgery. Yeah, very nice.
Great. Good. Okay, well, I will call it with that.
Do we have any interesting comments or questions in the Q&A, Shelley?
Yeah, let me just do a little blurb about our product, and then we'll get to the Q&A here. So, yeah, just before we open the floor to live questions, so we'd like to do just another quick little poll to help everyone continue their journey into bringing ultrasound guidance into your practices. So please do complete this poll if you'd like any information, and you can select as many as apply here. And while you complete the live poll, I'm excited to introduce you to the Clarius PAL, which we were both using, the dual array wireless scanner for whole body ultrasound. And as Dr. Eichholz was clearly demonstrating, you saw in the live video as well, or the live demo as well, it's 2 arrays in one scanner. So it makes it super versatile and ideal for anesthesiology. Clarius is unrivaled for near field and high resolution imaging. And best in class is what you need for great tissue and needle visualization. Clarius scanners are wireless, freeing up space with 0 footprint for ultra portability in a variety of settings. You get free movement with no wires getting in the way, touching your sterile prep area. And with no wires, Clarius is also faster to clean, disinfect, or fully encase in a sterile bag. Only Clarius delivers linear wireless transducers with an ecosystem that includes a free app for your iOS or Android devices for unlimited users. And available with our new membership, Clarius Cloud is available to easily capture and manage unlimited exams from anywhere. Your membership includes Clarius in-app classroom videos with experts like Dr. Eichholz and onboarding with a Clarius clinician to build your ultrasound skills. I'd like to share some information about an offer that we have for online CME credits. Clarius is partnered with FOMF, and as a Clarius customer, you are eligible for a discount to the annual FOMF membership. So please contact your Clarius rep for more details. Now, let's get to your questions. And a quick reminder that you'll all receive a link to the webinar recording, so do keep an eye on your inbox in the coming days here. So let's see what kind of questions we have. We have quite a few. We'll try to get to them before the top of the hour. How do you bring certainty of negative aspiration of blood with needle handling during providing the block?
Oh, yeah, that is a good question. So this refers to single hand injection technique. Yeah, as I tried to demonstrate, the position of the syringe in your hand is as such that you can use your thumb for either aspiration or injection. So you can aspirate while injection. And so when you start this, you should always aspirate. However, if you get more experience, I don't routinely aspirate anymore, because you will find like when you inject, you don't need 1 milliliter for like a test dosage or volume. You need 1/10, and you see a great spread given that your needle tip is in the scanning plane. So and of course, whenever I don't see my injection, I stop it instantly. But then it's only 1/10, and so you can aspirate, and the more experience you get, then you can put this in question whether this is really necessary.
Great. I like this question. Why do some nerves appear hypoechoic and others are hyperechoic?
Yeah, the reason is anatomy. And so whenever you scan nerves that are very close to the spine, the content of water is higher, and the content with connective tissue is lesser. So whenever you follow a nerve, like in the periphery, you get more connective tissue with it. And this is why you also get like this honeycomb pattern of a typical peripheral nerve. And so the reason is just how the nerves are built, and spinal nerves or close to the spine, this is hypoechogenic, and in the periphery, this is hypoechogenic. It's a mixture, and this is the honeycomb pattern.
Very confusing when you're learning, but okay. Do you use use on all amputation surgery the injection of local anesthetic intraneurally, like in the tibial nerve, to prevent phantomic pain?
Yeah, that's also a good question. Referring to the video I've shown before, of course, we would do this injection on the other end of the nerve, which is still part of the patient, of the patient alive. And of course, it makes sense to have a regional anesthesia with every amputation. And I think it can be discussed whether you inject it intraneurally. I personally don't do this. I do like a regular amputation catheter just nearby the nerve to prevent phantom pain. Absolutely.
Great. How about tips to improve success and safety in high BMI and short neck patients?
Yeah, well, this is our daily challenge. And so in high BMI, the first thing to do is high probe pressure to get your target structures closer to your footprint. And especially like imagine distal sciatic nerve block in a BMI patient over 40, then sometimes it's so hard to visualize this nerve because the probe pressure isn't high enough, and also the tilting of the probe isn't good enough, because as you probably know, that there is this phenomenon of anisotropy, which describes the characteristics of a reflective structure to reflect better or less good depending on the insonation angle. So probe pressure and tilting is the key to nerve identification in high BMI. And short neck, yeah, that is a problem. It starts with good positioning. So whenever there is a good rotation of the neck, some of the obese tissue gets out of your way.
All right. What about the possibility to block the cervical plexus at the level of splitting of the carotid artery just beneath the posterior fascia of the sternocleidomastoid muscle?
Yeah, that's also a good idea, and it works. However, my idea is coming from landmarks without having used ultrasound. We had outer landmarks to start with, and then with the ultrasound, we switched to inner landmarks. And one of these landmarks is the division of the carotid arteries. However, doesn't have necessarily to do with the neuroanatomy. So my target is the cervical nerve pathway, and to identify the nerves and then inject. So this is like a primary landmark is nerve identification. If you can't see them, you may as well use the bifurcation.
Great. We're almost at the top of the hour, but we've got just a couple of more questions. So I think we'll go over a little bit if that's okay with everybody. Someone has asked if you use a nerve stimulator for your blocks.
Personally, I don't use them anymore, or in very rare cases only. I use dual guidance, like in obese patients. Sometimes it is just good for nerve identification. So whenever you have difficulties with your scanning procedure, you are uncertain what the target structure is, you can bring your needle tip to what you think it is, and then double confirm it with a neurostimulation. But I don't use it routinely anymore. And this is a bit of shame, because some registrars, they don't really learn it anymore, but it's still a technique that is part of our portfolio, and it is still a good method to use. However, I think looking in future, it will eventually disappear. That's my personal opinion.
And there's a question about using sterile gel. Do you use sterile gel for your procedures?
No, I don't. I just use disinfection fluid and use this as liquid to, like for the sound, to be able to penetrate into the tissue.
All right. And there's just a couple of questions regarding intraneural or perineural injections in the nerve block. Is it supposed to be perineural or intraneural?
It is always supposed to be perineural and not intraneural, like in this amputation video. That was wrong. And so like a C-shape distribution of the local anesthetic is absolutely enough. We don't need what was in the literature in the years before. We were wanting a donut distribution of the local anesthetic all around the nerve, and this is not necessary anymore. A C-shaped distribution is absolutely enough, and this is perineural and not intraneural.
Okay, and let's do one more. It's just around billing. Is there a guide for optimum gain while performing nerve blocks?
No, I think this is basically a matter of personal taste, and there is only two aspects. So when you overgain the image, imagine you have like two white dots in the image, which are representing true anatomical structures. If you're overgaining the image, these two white dots will actually appear as one white dot. So the image quality will get lesser if you're overgaining, and the same thing if you're undergaining. So you got to find your right gain for the procedure. And for all the ones who are using the materials for teaching purposes, it is very often the case, like for the videos, that you have to slightly overgain them. Otherwise, you just download them and try to use them in a presentation, and then you see, it's all basically black. So overgain a bit.
Yeah, it is one of those things. Ultrasound's such a personal preference thing. I mean, some people like a darker image, some people like a brighter image. So as long as you can see what you need to see, then I think that's all that really matters, right?
Yeah.
Yeah. All right.
I have one comment because I was expecting one question.
Okay.
Maybe it's in there, but you didn't get down to it yet. So interscalene block or superior trunk block, why out of plane and not in plane?
Yes, I wanted to ask you that too.
Excellent. So that is good. I was expecting this because in Europe or in Germany, we're kind of used to doing it out of plane. And in the English-speaking countries, it is a standard in-plane procedure. And I think the reason is basically because we're used to doing it like this, and we have been taught to doing it like this. However, I think there are some reasons why it makes sense to do it out of plane, because, well, people keep telling me if you do it in plane, you always see your needle. That's a fairy tale. We've seen this. So there's rotation error and lateral shifting. Some others say out of plane, yeah, I can see the needle nearly always. That's also a fairy tale, as we've seen. So both methods have their challenges, but anatomically, if you don't control your needle doing it in plane, and if the needle tip is too deep, it is right in the superior trunk if it comes in plane. And also there are two nerves running through the median scalene muscle that you should avoid. Whereas if you do it out of plane, and if your needle is too deep, it is behind the plexus and not in the nerves. And this is why this is our method to do this out of plane instead of doing it in plane. But as an expert, you can do whatever you want, given that you control your needle tip.
Right. All right. Well, to be respectful of everyone's time, I think we'll call it there. And if we didn't get to your questions, we'll follow up with you by email in the coming week. I'd like to thank you so much, Dr. Eichholz, for all of your insights, and a very big thank you to all of you for joining us. In the meantime, have a wonderful rest of your day or evening or night. Keep on scanning.